insurance levy in March, and the fact that you are now have announced that you will actually not be meeting your commitment in relation to that. These new problems are arising from the Health Insurance Amendment Act 2012 and mean that everyone will pay the same additional levy, regardless of what type of private health insurance policy they held. During the debate on the Health Insurance Amendment Act last year, the Minister for Health made a clear promise that there would be a two-tier levy system for those with advanced and non-advanced cover, so that those with more basic cover wouldn't have to end up subsidising the more advanced policyholders. It was expected that those on basic packages would face a €5 increase, while those in advanced policies would face a €65 hike. However, following on from the recent review of all policies by the Health Insurance Authority, based on the wording of the Minister's legislation, they have found that none of the plans in the market at present conform with the Minister's definition of non-advanced.
Time is almost up.
Of non-advanced. And as a result, all policies are now categorised as advanced, meaning the same higher rate of levy will be applicable to all, and making a mockery of the Minister's pledge here in advance of bringing in the legislation with regard to the impact it would have. The other, in Deputy Kelleher's motion that he's put forward on behalf of our party here tonight, we're also asking, Minister, that you would address the health levy and the way its impact on children particularly. Because as you can see, that for parents who have the additional cost in relation to putting a child through college and to raising a family, they're finding it most difficult. And at least if you could address the levy cost on children, it would bring some ease to them. But overall, Minister, what we have to see is we have to see some meat in the bones of what you're proposing in terms of universal health insurance. Because the reality which has been delivered so far, 2/5 into this government's term, has been the opposite. Less people with health insurance rather than everyone with health insurance. And Minister, that is a real failure and indictment of your government, and what I hope to see is some sense of confidence that you and the government know where you're going in this, and some sense as well, Minister, that there's actually going to be real change and real movement in this. This is obviously going to be a long-term project, but Minister, it can only be a project if it actually gets moving and if we see progress in legislation. We haven't seen that.
Yeah, thank you. Now I'll call upon Deputy Michael Minahan, and you have 8 minutes.
I got Cahir, look, and I compliment Deputy Kelleher on putting down this motion, and I thank him for the opportunity to speak on it. I suppose it is one of the most an important range of issues, but I think there's a number of issues in relation to it. First of all, before I go into the motion itself and the issue in relation to people, there are anomalies in the system, and we meet from time to time as public representatives and people that come to us that would have had a paid-up membership of VHI and other insurances, and because of one application or one day in respite in particular, that the 2-week respite would not be granted under the cover. And also we had a difficulty in relation to the contents of a policy recently, where a person under the age of 30 had been diagnosed with a very serious cancer, and because of specific rules and regulations was put outside of the cover that they had, and wasn't able to benefit from the cover they had, even though that they had paid it, and indeed their families had paid it right through from the time that that person had been a young child and was outside of the system. So there are anomalies in the system, but I suppose the thrust of the motion here tonight is in relation to affordability of the VHI, and about families that are making decisions on a daily basis whether they can continue with the private health cover or not. And we've had many policies and flagged many policies in relation to universal health cover and all the rest of the detail in that. But the facts of the matter remain that there are families sitting around the kitchen tables throughout the length and breadth of the country tonight that are making decisions in relation to whether they are going to be able to continue with the private health insurance. And we have predominantly people that are within a certain age group that are making that decisions, people with young families, people that have mortgage difficulties, people that would have lost one or more jobs in the couple and maybe have a huge mortgage commitment and have all the other add-on costs about kids going to school, maybe kids going to college and so forth. And we come to a position where the families that are making these decisions are the younger age group and are putting huge pressure on. And we don't seem to see any, I suppose, urgency from government in relation to this issue. And there are whole rafts of this country, particularly, I suppose, the commuter belt, and indeed right across the country. It doesn't have to be there. In my own constituency, we see many, many people that are making these decisions for purely economic reasons, for purely reasons that they don't have the bobs, they don't have the money to make to continue with the health, universal health or the health insurance cover that they probably have had since they were born. And we are, I suppose, if you look at the statistics, and they have been quoted by previous speakers tonight about the amount of the numbers of people that are dropping out of the private health insurance market, and then we see the pressures on the other side of it. And all throughout the last number of years, the government opposite were telling us that they would have a plan in place, that they would have details in place, that they, almost at the touch of a button, that there was a solution to these issues, and there was going to be a solution to it. We have seen, the VHI in particular and other insurance companies, cycling up again for more increases. But as one of the previous speakers said, we have seen where the number of people that are availing of VHI cover having decreased dramatically, and the number of people that are working within that organisation have increased dramatically. And there is no logic coming out of it, or there's no reasons coming out, or they have never been able to explain properly how this correlates, because if it was in private industry or if it was in any other sector, it could not be equated, it could not actually add up. And we have seen then where some of the private health insurance companies have been giving us information where that they have achieved savings by negotiating with consultants and with other people on it. But the bottom line comes back that when the letter comes into the post, for the families, for the ordinary people that are working families with kids, when the VHI or the renewable policy comes in, it has increased. And they are faced with a very difficult decision, and that difficult decision, as it affects that particular family, and it affects that family as they make a decision on whether they can continue with voluntary health insurance cover. And I would have to say that during the 1980s, I came from a very exact same family who would have had private health insurance up to a point and had to discontinue that in the mid-1980s, and that had huge repercussions down the line. And I don't want to associate to dwell too much into my own personal family situation, but just to tell you that I would have experienced. And when it came about that parents of those families, if things improve in 10 or 15 years' time, and would be in a position to do it, they would be penalised to get back into the private health insurance market. And I think it behoves the Minister and it behoves the government to sit down and look at this in a logical and a sensible way and make sure that, that there is a reasonable decision made in it. And I suppose, if I can just expand the point in relation to the families that are making the decisions, they have now withdrawing from it, which is having a detrimental effect on the other people that want to continue in it, and has a detrimental effect in the increase in it. And nowhere over the last 2 years have we seen a robust defence of what is going to be done, except what was outlined in the programme for government. But we now need, at this point, we need a very clear indication that this is going to be tackled, and that the many, many families that are sitting around their kitchen tables discussing their finances and looking at what ways they're going to cut and what they have to cut back on to continue with the families, with the kids going to school, and with the extracurricular activities that are going on and all the other costs that are associated with it. And they are no way excessive in any way, shape or form, because the vast majority of people are looking at them in a realistic fashion. What are the government going to do from this point on, rather than just giving us if it was the roles were reversed, there would be huge, passionate pleas outside the doors of the House and elsewhere in relation to what we were doing wrong and so forth. The reality is that there is nothing being done in relation to the many thousands of people, the length and the breadth of the country, that are leaving the private health insurance. It's having a detrimental effect at those that are staying in the private health insurance, and believe you me, that in 10 or 15 years' time, this will have a bigger effect on the health service of this country going forward. We have seen the demographics, and we have seen what is likely to change in the demographics. But if we are not able to maintain the people that are in Middle Ireland, the people that are working to sustain families and sustain all the costs associated with it, if we are not going to be able to sustain them in the private health insurance market in the immediate term, or in the next 4, 5 or 10 years, when they will come to rejoin it, it will have a huge effect on it. And if they can't rejoin it, for the public purse and for the public policy, it would have a huge knock-on consequence. So I think that not alone for now, not alone for the families that are leaving in this very instance, but for the people in 10 or 15 or 20 years' time, and for society as a whole, this is a most fundamental decision to make. And I would appeal to the Minister to respond to the motion tonight, to respond to it and outline what's going to be done in the short term and what's going to be done to rectify the situation. I commend Deputy Keller for his motion to the House.
Thank you indeed. Deputy, I now call upon Deputy James Riley.
Thank you very much, Cathaoirleach. I'll be sharing my time with Deputies Mulhern and O'Mahony. Would you let me know when I have 2 minutes left, please?
Thank you.
I welcome this opportunity to participate in the debate this evening, and I would like to set out some of the progress achieved to date by my department, which underpins the development of universal health insurance by 2016. The preparatory legislative and organisational groundwork currently in progress for the universal health insurance system will be put in place and completed within this government's term of office. First of all, this government is the first in the history of the state that is committed to developing a universal single-tier health service which guarantees access to medical care based on need, not income. And we will, unlike the failed policies of Fianna Fáil, introduce universal health insurance with equal access care for all. Under this system, there will be no discrimination between patients on the grounds of income or insurance status. The two-tier system, presided over by Fianna Fáil for decades, will end. No one on this side of the House, contrary to your suggestions, ever suggested that the mess left by Fianna Fáil could be fixed at the press of a button. On the contrary, we were the first opposition at the time to be honest and mature enough to say it would take 2 terms of government to fix this and to put in place an equitable system. Now, listen.
You can go to
I didn't see anybody when I was listening to you on the monitor interrupting you. No. However, nobody likes to hear the truth, but as an old lady said to me once, the truth isn't fragile, doctor, it won't break. And the truth is that you and the government that you were part of had the power for 14 years and did nothing to address this issue. And could I just correct the record of the House, Cathaoirleach, because all sorts of outlandish claims have been made on the far side in relation to the increases in insurance. In 2009, health insurance went up by 11%. In 2010, it went up by 7%. In 2011, it went up by 10%, and last year it went up by 12.1%. So, the trend started actually in 2008. So for 3 and a part of those years, you had responsibility for us. You sold our financial sovereignty. You left us with the biggest debt the country has ever seen. And then you wonder why some of the costs of living in this country have to go up. It's quite remarkable, your vision of reality. However, I would like to mention that there are a number of other important stepping stones to achieving the goal of universal health insurance, and good progress is underway in the strengthening of primary care services to deliver universal primary care, as well as ongoing work on tackling waiting times and establishing hospital groups. When I came into government, I did set up the Special Delivery Unit in my department. The Special Delivery Unit, or SDU, started a major national programme aimed at helping hospitals to tackle the problems associated with delays in accessing care. Hospitals were set ambitious targets, and in the main they met them. And through meeting them, clinicians adopted new ways of working. And 2012 has seen significant improvement in hospital access targets, including a reduction of 23.6% in the number of patients waiting on trolleys in 2012 compared to 2011. And this equates to 20,352 fewer patients having to wait on trolleys. There are still too many people waiting on trolleys, but already in the first 2 months of this year, we've seen a further reduction of 10% on 2012. Now, I might remind the Deputy, because his memory does seem to fail him at times, that it was only 2 months or a month before the general election that saw the removal of your government that we saw the highest number of patients on trolleys since records began, 569. In relation to scheduled care, we set a 9-month target, and the number of adults excluding endoscopy having to wait more than 9 months for inpatient and day surgery was down to 86 at the end of December 2012, from 3,706 in December 2011, which is a 98% decrease. And the target for 2013 is a maximum wait time of 8 months. A 20-week access target for the number of children, excluding endoscopy, waiting over 20 weeks was down to 89 at the end of December 2012 from 1,759 in December 2011, which is a 95% decrease. And the number of patients waiting over 13 weeks for a routine GI endoscopy procedure went down from 4,590 in December 2011 to 36 at the end of 2012, representing a 99% decrease. Now, all this has been achieved despite the fact that we've had to remove, in all, $3 billion from the health budget over the last number of years, and that several thousand people, most of them last February, left the health service. And we are trying very hard to ensure that by the 30th of November 2013, no patient should be waiting more than 52 weeks for a first-time consultant-led appointment. So, I heard you earlier on saying that you'd cover more of this in your wrap-up tomorrow night, Deputy Kelleher. Maybe you'd be good enough to tell us why it is, despite all your years in power, that Fianna Fáil never even bothered to count the number of people who were waiting on an outpatient waiting list. This being the first government to do so, and not to be afraid to admit that there's a problem, and not to be afraid to say we will address it, and that we don't want any patient waiting longer than 52 weeks for a first-time consultant-led appointment by the end of this year. That is a very ambitious target. We will seek to meet it. Now, can I say in relation to access to GPs, there's now more than 1.8 million medical cards. It's the highest in the history of the state, and these have been issued to individuals. That's both the highest in terms of a percentage covered and also in total numbers of individuals. And also the bill to allow for the extension of free GP care to persons with prescribed illness will be published this year. And I'll be the first to acknowledge that we've been delayed in that regard through a combination of very serious technical issues, but also with the volume of stuff that has to go through the Oireachtas here. But progress continues to be made, and progress continues to be made in building primary care capacity and in chronic disease management, particularly for the management of diabetes. Funding has been approved for the appointment of 17 clinical nurse specialists whose role will include supporting healthcare professionals involved in the provision of care to their diabetes patients in both the primary and secondary care settings. In moving towards universal health insurance, community rating is a fundamental cornerstone of the Irish health insurance market. This means that the price of health insurance for all persons should reflect the principle of intergenerational solidarity. That is, that the entire community of privately insured persons should contribute towards the higher costs of claims for older people and less healthy people. On the community rating, everyone is charged the same premium for a particular health insurance plan, irrespective of age, gender, and the current or likely future state of his or her health. Community rating therefore means that the level of risk that a particular consumer poses to an insurer does not directly affect the premium paid. And I know that deputies on the far side of the House agree with that principle. The pricing of risk across the community of insured persons clearly requires robust mechanisms to share costs when there are several insurance companies in the market. The standard transfer mechanism to support community rating is called risk equalisation. The aim of risk equalisation is to look at the market as a whole and distribute fairly some of the differences that arise in insurers' costs due to the differing health conditions of all their customers. Community-rated health insurance systems across the world use this as a means of providing the necessary support for the market. An effective risk equalisation scheme creates an incentive for insurers to focus on innovation, greater efficiencies and improved customer service, rather than selecting customers on a risk-based. This is the kind of competition that is best for consumers. In this context, I am pleased to note that 2 major reinsurers are now involved in providing underwriting services in the Irish market. In the lead-up to universal health insurance, it is critical that private health insurance remains affordable and that the market is competitive. And I welcome the fact, therefore, that there are now 4 insurers competing in the market. So if our policies were so erroneous and misguided, Deputy, we would not have the market with further insurers coming into it. Clearly, what they value is certainty into the future, and they can see the risk equalisation for what it is, and it gives them the sense of certainty they need to feel that they can compete in that market. The Health Insurance Amendment Act 2012, which I introduced last November, provided for the introduction for the first time in this country of a permanent risk equalisation scheme in the private health insurance market with effect on the 1st of January 2012. And I was gratified that that legislation was strongly supported on all sides in the Dáil, and this support was a clear recognition of the vital part which a risk equalisation plays in maintaining stability in the private health insurance market. The scheme provides that health insurers receive higher premiums in respect of insuring older people, but that older people receive risk equalisation credits equal to the amount of the additional premium, so that all people continue to pay the same amount for a given health insurance product. The risk equalisation scheme encourages efficiencies as it compensates insurers for only a proportion of the higher cost of insuring older and less healthy people. Insurers should then compete for market share by providing better services rather than competing for younger, healthier lives. The risk equalisation provides for a cost subsidy from younger, healthier people to older, less healthy people. The compensation is provided in favour of the individual consumer and not in favour of any particular insurance company. A company with a worse than average risk profile and therefore higher claims costs will be a net beneficiary from the scheme, while a company with a great proportion of younger and healthier people will be a net contributor to the scheme, but will benefit considerably from having much lower claims costs. In setting the rates for risk equalisation credits following consultation with the Minister of Finance, I had particular regard to the principal objective of the Health Insurance Act, which is to ensure that access to health insurance cover is available to consumers with no differentiation between them, in particular as regards the cost of health services based on health risk status, age or sex. I also had regard to the aims of maintaining the sustainability of the market, having fair and open competition in the health insurance market, and avoiding the risk equalisation fund of having a surplus or deficit from year to year. So if the risk equalisation is set at an appropriate rate, it should indeed meet its costs and not more. In operating the risk equalisation scheme, it's important to ensure that those who buy the more basic plans with lower levels of cover do not effectively subsidise customers who decide to purchase plans that provide higher levels of benefit. And with this in mind, the Health Insurance Amendment Act 2012 distinguishes between non-advanced and advanced plans. The non-advanced or entry-level plans will have a lower rate of stamp duty payable. In addition to avoiding any unintended subsidisation of advanced plans, they also help to make the entry-level plans as affordable as possible. I am conscious of the concerns that have been expressed regarding the absence to date of any non-advanced plans which would attract a lower level of stamp duty. It is important to note that the new stamp duty rates will come into effect for policies taken out from the 31st of March onwards. While there are no non-advanced plans currently in place, the focus will be on availability of such plans from the 31st of March, when they can start benefiting from the lower levy. It opens, no, sorry, that was your policy. Sorry, dear boy, don't get confused between your policy and ours. It is open to insurers to introduce new non-advanced products at any time, subject to meeting the qualifying criteria and adhering to a 30-day notice prior to the to the Health Insurance Authority. I understand, Deputy, and I'm sure even if you're not interested, your constituents will be, that insurance are currently engaging with the authority in this regard, and that over 30 products, 30, are expected to be available to consumers from the end of this month. I want to turn now to the issue of costs, one that is fundamental to the government's programme of reform. I am not satisfied to accept that medical inflation is in some way special. I do not accept that medical inflation should be allowed to jeopardise affordable healthcare. I have emphasised to insurers to do everything possible to keep down the cost of health insurance so that it is affordable for as many people as possible. I have consistently raised the issue of costs with health insurers, and I am determined to address the costs in the sector in the interest of consumers. Last year, I established the Health Insurance Consultative Forum, which comprises representatives from the country's main health insurance companies, the Health Insurance Authority and the Department of Health. This forum was established to generate ideas which would help address health insurance costs, whilst always respecting the requirements of competition law, and also give a voice to the insurers in the development of a new universal health insurance model. I have made it clear to the health insurers that I believe that significant savings can still be made, the effect of which can be to minimise the need for an increase in premiums. I have requested the VHI in particular to address its costs as a matter of urgency. In particular, I have asked them to focus on auditing the volumes of procedures they pay for, and to audit from a clinical perspective the appropriateness of procedures carried out before they fund them. I have also stressed to the VHI that they should critically examine the actual prices they pay both to the health professionals and to private hospitals. I have emphasised the steps that I expect to be taken across the private health insurance industry so as to keep costs and resulting premia down. I could hear just over 2.09 million people currently have private health insurance, which represents 45.8% of the population. Numbers insured have fallen by 63,000, 2.9%, in the 12 months to end of 2012, which is a continuation of the declining trend since the peak of 2.2 million, or 50.9% of the population, at the end of 2008. This reflects the general economic downturn Ireland is currently experiencing. For those who have been insured in the same plan for a number of years, it's important that consumers review the level of cover to ensure that their needs are being met without being over-insured. Consumers have a legal right to switch between or within insurers to get better value and to reduce their premium costs. The government would strongly advise consumers to shop around for the health insurance plan that best suits their needs. The Health Insurance Authority provides information to consumers, and the health insurance website www.hia.ie has a useful plan comparison tool which assists in finding suitable and competitive health insurance plans. Since coming into office, I have made some significant improvements to the measures in place to ensure that private health insurance remains affordable for older and less healthy people. In order to keep down the cost of health insurance for older people with effect from the 1st of January 2012, I increased significantly the age-related income tax credit for insured persons aged 60 years or older. Without this support, health insurance would have had an even stronger financial incentive to segment the market by offering policies targeted at young people to the disadvantage of older customers. With effect from the end of March 2013, the risk equalisation credits will decrease substantially over 2012 levels for higher risk groups, particularly men aged 70 and above. For example, the risk equalisation credit for a 75-year-old male with advanced cover has increased by 400, which is 20%. The risk equalisation credit for an 85-year-old male has increased by even more, 675, or 25%. The Health Insurance Authority has confirmed, based on market average claim costs for prescribed benefits, that the 2013 scheme compensates for 75% of higher claim costs for those aged in their 70s and compensates for 83% of the higher claims costs for those aged in their 80s. An additional consideration regarding the cost of healthcare delivery concerns the charging for public bed occupancy. Under the current legal framework, private inpatients who occupy public beds in public hospitals are not levied the daily maintenance charge, which ranges from €586 to €1,046 in most public hospitals. The Controller and Auditor General reported in 2010 that 45% of inpatients treated privately by consultants were not charged maintenance costs because they were not occupying designated private beds in public hospitals. I have previously announced my intention to bring forward legislation to address this. As part of Budget 2013, I announced further details on legislation to provide for the charging of all private patients in public hospitals. Primary legislation will be introduced during 2013 to provide for charging of private patients in public hospitals where they're not in a designated private bed. On that basis, sorry, 2 minutes, thank you very much. On that basis, 2013 has provided for an additional patient income of 60 million in 2013. This measure is designed to recoup some of the cost of treating private patients in public hospitals. The present system, where private patients are charged only €75 per day when they occupy a public bed, represents an unsustainable subsidy to health insurance. It is not fair, Deputy Kelleher, and I am committed to addressing it by charging a realistic amount for this service. May I say the recently published Money Follows the Patient policy paper proposes the introduction of a new model of funding for public hospitals care. It involves changing from the current inefficient system of block grant budgets to a new approach where hospitals are paid for the actual level of activity they undertake. This will be facilitated through the introduction of a prospective case-paid payment system using diagnostic-related groups. The changes will effectively mean that hospitals will be funded on the basis of the quality and quantity of services they deliver to patients and not the size of last year's budget. This move is in line with the recommendations of a value for money policy review which previously examined the issue. And basically what it means is if there's no patients, there'll be no payment. I'd like to just mention the national clinical programmes, and these have been in the interest of all patients, public and private. That is that effective clinical pathways are put in place across the health system. National clinical guidelines will help further improve the quality and safety and cost effectiveness of healthcare across Ireland. In the public health system, the HSE continues to work on the national clinical programmes to improve and standardise patient care throughout the system. And can I just mention the stroke programme, which has saved 1 life a week since its introduction, and indeed preempted the necessity for 3 patients a week to go into long-term care. We've also got a new early warning scorecard, which is going to make a huge difference right across the system. We're the first country to put it in place nationally, so that doctors and nurses in Tralee will be operating on the same value set as doctors and nurses in Letterkenny or Beaumont or James's. As I said at the outset, the government is embarking on a major reform programme for the health system, the aim of which is to deliver a single-tier health service supported by UHI, where access is based on need, not income. I've already outlined a number of important stepping stones which are underway to pave the way for universal health insurance. Contrary to the claims made by the opposition, I believe we are taking the right steps to achieve a sustainable, robust private health insurance market. The risk equalisation legislation is a key element of this. Taken with the actions on addressing costs in the market, I am determined to ensure that private health insurance remains affordable. My concern is to ensure that the private health insurance market is ready to form a key building block for universal health insurance. In the meantime, the government will work intensively to ensure a well-functioning insurance system for our people. And finally, I would urge insurers to take all appropriate means to address their costs and to keep premium rises to the absolute minimum. I believe there is much room for improvement.
Minister, before you sit down, I'd ask you to move your amendment. Can you move that?
Please now, from a technical point of view, could I move the amended motion, please? Thank you.
Thank you. Minister, I'll now call upon Deputy Michelle Mulhern. You have 5 minutes.
Thank you, Cathaoirleach. I welcome the opportunity to speak to this motion. What can we say about health insurance? It's one of the vicious circles that we have to deal with. The more people that leave it, the more expensive it becomes, and then more people leave it again. And clearly, it's an issue for lower income families, not least on account of the fact that if you're on a higher income, you're getting your tax breaks on your premium that you pay for your health insurance. But obviously the measure of the cost of cover, say 3,000–4,000 for a family, isn't based on what your income is, it's based on risk and so on. So I think that any steps that can be taken towards people who are genuinely wanting to have health insurance but find that it's just outside their grasp should be pursued. And as I say, and also recognising the fact that depending on your income, that the tax break isn't as attractive or significant to lower income families. I welcome very much the concept being pursued by the Minister of money following the patient, and I suppose it makes sense in its plain English sense as well, that hospitals and health services are paid for on the basis of the service they provide and not just blindly giving out a block grant, which in the detail can lead to inefficiencies. So I welcome the teasing out of that and the development of it towards a more efficient system, and indeed as we move towards universal health care, which will be very much welcome when that arrives. Yes, the onus, though, I think we forget sometimes, is also on health insurance companies to challenge the costs being made by hospitals and consultants, and in doing so bring down the cost of health cover. I would say in some cases insurance companies are just handed out a bill, and there's very little checking to see, you know, what they're getting for their money, and they just simply pay out the money. And I think that they equally have a role to play in demanding the efficiencies that we need to see going on in hospitals, and including usage of step-down beds, and even, say, for example, I think we really need to think outside the box. If somebody comes in for a day procedure or something, there could be a day procedure, but they might need to be seen the next morning or checked, perhaps that individual could be put into a hotel at a lot lesser rate, you know, as I say, depending on their medical requirements. But we really have to look at the costs and, as I say, be creative in how they would be cut back, and at all times that we look towards bringing those costs down and making health care and health insurance affordable. While I have the opportunity, Minister, I'd just like to briefly raise the issue of the Fair Deal and problems that are being encountered there, where older persons are experiencing inordinate and excessive lengthy delays in having their Fair Deal applications dealt with. And so it means that these people are not just remaining in local hospitals and taking up those beds which are required as step-down facilities, local community hospitals, but in some cases are in acute hospital beds. And obviously that causes a backup then in the other side where we've got people on trolleys. It's not a case that there isn't money been put at or put towards caring for the elderly in long-term residential care. We know that, say, last year alone, approximately 1 billion and over 22,500 people were provided for through schemes such as Fair Deal and subvention. But nonetheless, this problem prevails, and it is a real problem for hospitals that are experiencing blockages, that people actually cannot get out of the hospitals because they can't get approval under the Fair Deal scheme. And I'm not sure that I can say how it can be addressed, because obviously there's the problem on the other end where properties are secured after somebody's death, but you cannot sell a property now. And also the question is, what is the market value of a property where you can't actually sell it? So there's obviously inherent problems there on account of the way the economy is and the way the property market is. But it definitely, from the point of view of efficiencies and us taking up expensive hospital beds, something needs to be done about the processing, the more rapid processing of Fair Deal. Thank you, Minister.
Right. Thank you, Michelle. Now I'll call on Deputy John O'Mahony, and you have 5 minutes.
Thanks, Cahirla, and that contribute to this private member's motion. And I acknowledge that it is an issue out there among the concern among the general public, and to thank Deputy Keller and Fianna Fáil for raising it. But I suppose it's also important to point out that this hasn't just become an issue in the last 2 years. You know, the price of private health insurance, for instance, on the average policy increased by 11% in 2009 as well. So it's an issue that is going back for a number of years, and we are aware of the declining trend in membership. From a peak of 2.3 to 2.1, and that 67,000 people left or gave up their policies for private health insurance last year. And of course the problem then is exacerbated by the fact that it's the younger people that can't afford it, that have so many other issues, whether it be employment or mortgages or whatever. And once they opt out, it puts pressure on the health service. and it also puts pressure on the increased prices for the membership, because they are obviously under the schemes that we have and the methods that's used. There's less money to subsidise, if you like, the older people, where there has been an increase in membership actually by 12%. And I suppose the need for community rating and the concept of risk equalisation is accepted by and large, but where it sees everybody charge the same premium for a particular health insurance plan, irrespective of age, gender, and the current or future likely risks in their health. However, this can lead to anomalies. A constituent of mine, a male constituent, came to me recently and he asked me, why does he have to pay for maternity cover when he doesn't expect to get pregnant anytime soon? You know, why couldn't, for instance, their private health insurance provide a range of, if you like, or a menu of packages that the person can pick what he wants and get his cover for that, a bit like maybe our car insurance, whether it's third party, fire and theft, or comprehensive or whatever. Because I suppose there needs to be, we look at these and need to look at it in new ways. I suppose the other thing that sometimes I get the view there, meeting members of the public, that there's benefits to be had from shopping around, and at the end of the day, you know, maybe it's happening now, but it certainly didn't happen up until recently, where you know, where members aren't or didn't take advantage, if you like, of the competition there between various companies. And you know, there's a tendency, I suppose, especially with our maybe older generation, to stay with where they have been, and so there are large savings to be made on, if you like, shopping around and looking at the various health premiums. It's important to review the level of cover and to ensure that their needs are being met without being that they're not over-insured. And you know, some people are spending money, or have in the past spent money on being over-insured, and then I don't think people, to a certain extent, the message isn't out there that people have the legal right to switch between or within insurers to get better value and reduce the costs.
Deputy.
One final thing that I'd like to say here is that as regards private health insurance companies and the pace at which they pay hospitals for procedures, I was astounded at the end of last year to realise that in the HSE West region there was €47 million owed to hospitals in the region, and in the case of Mayo General Hospital it was almost 5 million, 4,208,000 to be exact. I mean, that's a huge figure and simply not acceptable, and I commend the Minister for the efforts that he made in reducing that. I think Galway University Hospital and Merlin Park were over 10 million, and at a time when hospitals are trying to meet budgets, they need to get the money that they're due. Thank you.
Yeah, thank you, Deputy. Now I call upon Deputy Cuivan O'Quailon, and you have 10 minutes.
I wish to move the amendment in my name to delete all words after calls on the government to, and insert the following: in the interim, ensure the proper working of the system of risk equalisation to support the community rating principle, entailing the transfer of compensation from insurers who carry lighter risk burdens to those who carry heavier risk burdens, preventing unregulated market discrimination against the old and the sick, or any other group or individual that insurance companies may decide are at greater risk, take measures to improve access to health care for all who need it, abandon its plan to base the health system on the discredited model of competing private health insurance companies, adopt a new approach based on universal access to equitable and efficient public health services based on medical need alone, funded from fair general taxation. The focus of the motion before us this evening from Fianna Fáil is on health insurance. And it should, in my view, be on health care, on how we fund our healthcare system. The first part of the motion describes the situation as it is and is not objectionable. The second part is not acceptable to me and to my colleagues in Sinn Féin. It supports the maintenance of the current two-tier public-private system that is at the root of the crisis in our health services. And this is not surprising. More than any other party, Fianna Fáil are the architects of the grossly inequitable two-tier system that has afflicted the delivery of healthcare in this state for decades. A former Fianna Fáil health minister said that the two-tier system had served us well. At least he acknowledged it was a two-tier system, but his successors pretended that healthcare apartheid did not exist. We saw the private healthcare system piggybacking on the public system at huge cost to the state and the taxpayer, and above all, at the expense of the public health system. Citizens were paying for health through taxes, through charges, and in many cases through health insurance premiums, and that situation maintains. In office during the Celtic Tiger, Fianna Fáil, under a succession of ministers, Micheál Martin, Brian Cowan and Mary Harney, boosted the private for-profit health sector as never before. Property-based tax breaks enriched the privateers, private health insurance was encouraged, and the failure to properly reform and resource frontline healthcare services as distinct from the HSE bureaucracy led many citizens to conclude that private health insurance was the only guarantee of decent healthcare. And this, of course, has all been followed by the inevitable collapse. There has been a massive decline in the number of people with private health insurance. In 2008, there were 2.3 million people with private health insurance. In 2012, that has dropped to 2.1 million, and the cost of premiums is rising. People who have dispensed with insurance because they can no longer afford it are now totally dependent on the public health system, which is under attack from this government's failed austerity strategy. And the state continues to heavily subsidise the private for-profit health system with private beds in public hospitals, a fast track to care for private patients, while public waiting lists grow, and the dual working of hospital consultants in the public and private sectors continuing apace. As I said in the debate on the Health Insurance Amendment Bill 2012, it is supposed to be a protection against the working out of the raw profit motive in the health insurance sector. It is supposed to be based on solidarity between generations and between the healthy and the sick. That is welcome insofar as it goes. But we in Sinn Féin would go much further, extending the principle of solidarity to the way we fund, organise, structure and manage our entire healthcare system. That bill is based on the recognition that there has to be social solidarity within the insurance sector, that the market has to be regulated to prevent price discrimination against the old and the sick. So normal commercial competition cannot exist. Otherwise, we would have a US-style law of the jungle where the young and the fit would benefit from cut-price health insurance and the old and the ill would be fleeced or driven out altogether. Instead, the principle of social solidarity is recognised. And that's, of course, a very, very welcome position, at least to start from. So why not then take the next step and extend social solidarity across the entire healthcare system? That's my appeal to the Minister here this evening. If you take that solidarity to its logical conclusion, then you move to a system of universal provision of healthcare based on need and need alone, and not on ability to pay. The question then is how you pay for such a system. Contrary to the frequent assertions of the Minister and other voices, we in Sinn Féin recognise that healthcare is hugely expensive and has to be paid for. The question is how to pay for it in a way that ensures the best possible healthcare for all who need it, and which does so with the best achievable value for money. The Government is proposing to bring in universal health insurance, with the state subsidising those who cannot afford to pay insurance premiums. The state will still have a huge regulatory, managerial and funding role. Why then give private for-profit insurance companies such a central place in the system? What contribution will they make? They are funded by the consumers who buy their products. The insurance companies, on behalf of policyholders, will buy services from private or public hospitals or other service providers, and they will have to make a substantial profit in the process. Their shareholders will expect it, indeed demand it. Why not cut out that profit for the privateers and keep that money in the health system and in the pockets of our citizens? The only possible reason for not keeping out the profiteers is not a healthcare reason, it is a commercial reason. In going for the privatised insurance model, albeit including a slimmed-down VHI in the mix, the government is putting business before health. For citizens, the bottom line is that when they need healthcare, they need it promptly and they need the best care possible. We're all exactly the same in that regard. And that is why we in Sinn Féin advocate universal healthcare based on equal access for all. We want that to be state-provided, funded from fair general taxation, and free at the point of delivery. This would involve a higher contribution in tax from the highest earners than they contribute at present. We do not favour the model of insurance-based funding for the reasons I have outlined. If health insurance is to be the basis for funding, then it should be a state insurance scheme. Labour once claimed to be in favour of this, but their former policy has been suppressed in favour of Fine Gael's stand on this matter. The least desirable model, as far as we are concerned, is an insurance system based on competing private health insurance companies. In that case, the profit motive and the interests of shareholders becomes paramount rather than public health. This is the Fine Gael model, and this won out quite clearly in the programme for government negotiations. On the 8th of November, and I've referred this to the Minister previously, the 8th of November just passed, the trade union Impact published an important paper entitled The Future of Healthcare in Ireland. And it says of the government's plans, and I make no apology for putting it on the record once again, the government model of competing private sector insurers has not been properly tested. Delays in its implementation suggest that government plans for UHI have been poorly thought out. If implemented, the model is unlikely to deliver equity, value for money, quality or universal access. Quite the opposite. Lessons from the Netherlands show that a profit-driven commercial model led to an inequitable and inefficient system of funding, different tiers of entitlement, rising hospital deficits, and even bankrupt hospitals, unquote. Now, that is a very different view of the Dutch system to the glowing reviews of the Minister and of Fine Gael. The Impact paper recommends examination of what it calls a single-payer social insurance model along the lines of France, Germany and the Nordic countries.
Deputy, your time
states...
time is just up now.
Well, may I just finish?
Yeah, okay.
It states quite rightly, we believe, that the competing insurers model should not be adopted before all the options have been evaluated in terms of equity, quality, access to services and value for money. My time is concluded.
It's okay.
Well, in that case,
Give me another minute.
Yeah,
you can take a minute.
May I take a minute? Well, thank
you.
It's good to have friends in the House. At present, we have decreasing numbers of people with health insurance, rising premiums for those who have, more pressure on the public health system from those coming off insurance, and the persistence of the two-tier public-private system, with the struggling public system subsidising the private system. That's the fact. We have calculated, based on figures from government itself, that if the government applied the full cost of private beds in public hospitals, it would save 432.5 million, a sum that could then be spent in the public system, reducing waiting times and overcrowding in our hospitals and improving services. We must ask, what is the real prospect of change under this government? Already the promised extension of free GP care has been postponed. The programme for government promised the white paper on financing universal health insurance early in the government's first term. The Department of Health's recent briefing for the Oireachtas Health and Children Committee says it will be published as early as possible within the government's term of office, and we are all still waiting. In conclusion, Cathaoirleach, going the insurance route is a mistake in my belief, certainly this private insurance mix. It offers the increasingly remote prospect of reform, while the deeply flawed current two-tier system deteriorates, especially as a result of the austerity policy and health cuts of this government that are undermining the public health system. Accordingly, I urge support for the Sinn Féin amendment to the motion before the House this evening.
Okay, thank you, Deputy Senator McKinnon. Please, you have 2.5 or 3 minutes. But
I welcome the opportunity to speak on this bill, and I would like to thank Fianna Fáil for giving us the opportunity to discuss this important issue. Like my colleague Caoimhín Ó I do not in theory have a problem with the first section of the Fianna Fáil PMB. However, in keeping with Sinn Féin policy, and indeed my own views on this subject, I must say that I have serious concerns, both politically and ideologically, with the second part of the PMB. Therefore, I support my party's amendments and concur with the view that this motion should be about health care and not, as Fianna Fáil would have it, private health insurance. Any discussion around the issue of health insurance, no matter how politically progressive and socially enlightened, carries with it a subtext around issues of access, management and profitability. In other words, who can afford to pay, how much will it cost, and how efficient will it be? In planning or imagining a decent healthcare system for a modern state in the 21st century, these questions merely serve to reinforce, both in material and ideological terms, the system of apartheid which currently exists in the provision of healthcare in Ireland. That Fianna Fáil would wish to perpetuate this system should of course come as no shock. After all, when in office, Fianna Fáil under Ministers Micheál Martin, Barry Cowan and Mary Harney vigorously pursued a policy of vulgar privatisation of the state's health service that, as we now know, has had a devastating impact on the provision of public health care in this country. Today our public health care system is essentially broken, and this is in spite of the gallant efforts of the medical, nursing and domestic staff who work tirelessly day in and day out to keep the system going. We have the appalling situation where the working poor and the underemployed will delay going to the doctor due to the high cost associated with such a visit. We have many people who cannot afford to pay for medication because they simply just haven't got the money. Seriously ill people wait for months, if not years, to see a specialist. The free dental scheme, which is so important for the disabled, the poor and the vulnerable, has been all but dismantled. This is unfortunately the reality of healthcare in today's Ireland. We have a dysfunctional public healthcare system, which in large measure legacy Fianna Fáil's love affair with privatisation. Tonight's PMB in many ways reflects this distorted thinking about healthcare. Any discussion about the provision of healthcare must begin from the premise of universal access. For-profit models do not belong in this discussion, as they serve to reproduce a system that is inherently unequal and seriously disadvantages the working poor and the vulnerable. Sinn Féin is committed to building a universal public healthcare system that is found in most modern advanced states.
Deputy Seamus Healy and Thomas Spring, you have 2.5 minutes each, give or take.
Thank you, Cathaoirleach. Cathaoirleach, the private health insurance industry is in crisis. As we know, almost 70,000 people have left in the last 12 months, simply unable to afford the premia, which have been pushed up year after year after year by huge levels of inflation, way above the normal levels of inflation, way above health sector inflation. young people are simply not able to afford the premium now, and of course that is pushing up the payments and the insurance premium for the remaining people, mainly older people. So it is simply unwise and unsustainable to hand over our public health service to competing health insurance companies. I believe that's unacceptable and it's unsustainable, and we need to provide a public health service where access is based on medical need and on medical need alone, which is funded from general taxation and which is operated by a body which is transparent, which is publicly accountable and which is widely representative of all stakeholders, including patients and staff. Importantly, and is legally obliged to consult stakeholders prior to any decisions being made. And that brings me, Minister, to an appalling situation which we had in South Tipperary over the last week, where a decision to transfer a rehabilitation unit from St Patrick's Hospital in Cashel was made without absolutely no consultation whatever with patients